So next, Gareth Bate, who's our Senior Vascular Clinical Nurse Specialist, is going to talk about setup, coding and reimbursement. Gareth and I don't know how many thousands of foam treatments we've done, but it must be quite a few.
Quite a few.
and in some very nice places.
Yeah. And it's kept me off the streets for 15 years, so that's quite good. Very good. Right, so you've heard about the evidence and the science. What about some practicalities in terms of setting up a service if you don't have one, the equipment you need, the costs involved, coding and the reimbursement that's available through the NHS. What do you need to do foam? Well, you need a room. Preferably it should have hard flooring and not carpet, and preferably it should have somewhere to wash your hands. This is one of the rooms that we use. This is a treatment room attached to our day surgery unit, but really the room doesn't need to be this big. And as long as you've got room to swing the proverbial cat, you've got room to do foam. You need a couch for the patient to lie on. Ideally, it should be able to go up and down. It's nice if it breaks so that the patient can sit up a bit. It's often easier to cannulate veins with the patient in a semi-recumbent position rather than supine. And if you're really flash, you can have a couch that tilts because that sometimes helps keep the veins dilated whilst you're cannulating them as well, but it's not necessary, it's just a luxury. You need an ultrasound machine. We use a Sonocyte Micromax. It's 8 years old now and it's very battered, but it still works. You need a high frequency probe, 10 megahertz or greater. And you need to know how to use it, of course. You need a drip stand or something to elevate the patient's leg. And you need a trolley with a bit of kit on. Most of the kit that you require will be readily available in your centres already. A few syringes, 3-way taps, non-sterile gloves, some tape, some local anaesthetic, some saline and all this sort of thing. There's a few specifics though. First thing I would say is not all intravenous cannulae are equal. These are the cannulae that we like. They're called Optiva 2. They're very low profile and very sharp. Most of you, I think, will have the modern safety cannulae available in your wards and departments, and these are really not ideal to do foam. Some of the veins that you cannulate, particularly if you've had patients with venous hypertension for years, can be pretty scarred and hard, so you need a sharp cannula with a low profile to get into them. The other thing about these things is that they can be resheathed, so you can juggle them around a little bit. Something else that we're very fond of is this thing. This is a B. Braun 5 micron filter, which you may be able to find on your intensive care unit. If not, we recommend that you order them if you're going to do some foam. We attach these to a 3-way tap as shown and oscillate the sclerosant through this apparatus, and this provides a nice homogeneous foam with very small bubbles which stays stable for quite a lot longer than if you don't use the filter, we feel. The other thing that you probably need if you don't have it already is some Pearhaft bandage. This is a lightweight, short stretch, cohesive bandage that we put on underneath the elastic hosiery for a few days. This means that patients have a combination of elastic and inelastic compression immediately after foam, so they get quite high compression when they're ambulatory but lower compression when they're resting. And of course you need some sclerosant. This is an old slide, forgive me, the modern fibrovein doesn't have the hyphen in the middle of it. And when it comes to foam, we're only talking about the 1% and the 3% strengths that we use. In terms of the costs involved, you may be familiar with this paper from Manj Gohil and the Imperial Group published 4 years ago. They looked at all 4 techniques for treating varicose veins and came up with these costs. I have to say that when I looked at this, I thought that this was a gross overestimation of the cost for foam, and I did a sort of bit of a back of the fag packet calculation in terms of the costs that we incur, and this is what I came up with. I should point out that this includes operating costs, so this is half an hour of a professorial time here, roughly £72.50 for the professor, and half an hour of my time, which is about £2.50. And I've also built in £10 for depreciation of the ultrasound machine. I couldn't think of anything else. Really, it's a very cheap procedure to do, and I came up with a figure of about 163 quid, so who knows. Compared with RFA and EVLT, well, in our trust we use RFA. We don't have laser, but we do get a bit of a discount from Covidian for the VeniFit catheter, and we pay £345 plus VAT per catheter. The laser fibres, pretty much regardless of which fibre you use, come out at around £245 plus VAT. What you've got to remember on top of that is that there's an 80 quid cost for the procedure pack, and this doesn't take into account operator time, stockings, or any of the other kit that you use. So foam is considerably cheaper than either of the endothermal techniques. In terms of coding, the OPCS code for foam sclerotherapy, unilateral foam sclerotherapy, is L8620. We never do bilateral foam sclerotherapy, so that's the only code you need to know, really. In terms of reimbursement, grateful for some help from our clinical coding people and contracts people, and also Mark Scriven, who's our clinical director here at Heft. The reimbursement we get for foam sclerotherapy is £912. This is obviously NHS. Anybody care to hazard a guess as to the reimbursement from the endothermal techniques? Anybody know? It's exactly the same. £912. Anybody care to hazard a guess about day case surgery, unilateral varicose veins day case surgery? Anybody hazard a guess? It's exactly the same. I don't think I need to say very much more about that. It's fairly, we make a decent profit when we do foam on our patients. You can actually slightly increase the amount of reimbursement if you code accurately. And the code for any varicose veins procedure with complications, for example, if the patient has a leg ulcer and you record that on the KMR1, you do get a little bit more money for it. We got £1,023 the last time we coded one of these. So just thanks to those people for helping with these figures. So really that's about all I've got to say. I had 5 minutes. I hope I've stuck to the time. Thank you very much.